Again, good morning, my colleague. Let's start our chest Viva oral and long cases. This is a 30-year-old female patient. I think this is not the first case. This, this is the first case. Okay, this is
Okay.
30-year-old female patient presented with diffuse body aches and headache and neck pain. Go on.
Okay, so I'm presented with a lateral radiograph of the cervical spine in an elderly female. The striking abnormality is um, uh, cortical irregularity at C3 vertebral body with a lucent lesion seen in the anterior vertebral body. I don't see any malalignment of the cervical vertebra. I don't see any obvious fracture lines. I see similar appearance and see C7. The prevertebral is not widened or
Are you sure?
I don't
Are
see
you
any
sure?
airlock use.
Look again,
Maybe
please.
minimally widened or yeah, yes.
Hmm.
There's a prevertebral space widening, but I don't see any airlock use within.
Yes.
Um, okay, so because of the widening and the lesions in the vertebral bodies, I would like to proceed with CT to evaluate this further.
Okay, but this patient have a whole spine X-ray. What do you think?
Okay, okay. So I see soft tissue opacity at the right paravertebral region. Sorry, left.
Okay,
Um,
excellent.
okay, I'm evaluating the abdominal structures. Visualize thoracic cavity. I don't see any free air or cavitary lesions. I don't see any abnormality overlying the psoas shadow. Um, so in view of the thoracic spine findings, I'm thinking this could be a left paravertebral collection.
Yes. What's your next step?
Okay. I will proceed with the CT chest.
You can check. 1 second, I think okay. Fine. Why? Why you wanted to do CT check? What's your concern? What's your primary differential diagnosis?
I'm thinking of either an infectious etiology or metastatic lesion.
Okay, go on.
So this is cervical spine CT, sagittal
Yes,
bone window.
yes,
There is multi-level cervical vertebral body destruction with the loss of congruity of the anterior cortex, most notable at C2, 3, and 4. The similar lesions are seen in the lower cervical vertebra. Um,
yes.
can I check the soft tissue window?
Sure. The soft tissue window.
Okay, so the soft tissue window, I see soft tissue thickening or collection and the anterior to the vertebral bodies, with again redemonstration of the underlying destruction of cervical vertebra.
Yes,
I cannot see any. Oh, there's a supraclavicular lymphadenopathy.
yes.
I would like to scroll further down. to check. The thyroid appears unremarkable. There are no nodules or mass lesions on the thyroid.
Yes. What's your
And
diagnosis,
in
doctor?
the mediastinum,
Doctor, what's your diagnosis?
so likely an infectious etiology, possibly TB.
Do you have any clue here in this cervical CT that can prove this is TB or not? Do you have any clue?
Uh, the subligamentous spread of infection.
What else?
Um,
What else?
a sparing of the disc spaces.
Okay. I think there are MRI. This is not MRI. Yes. Look here. Especially here.
Okay, this is okay. This is MRI of the spine, axial cuts of in T2. I can see there is destruction of the cervical vertebra. There is a prevertebral
Cervical
soft
or
tissue
dorsal?
collection.
Cervical or dorsal?
Sorry, this is
Dorsal.
dorsal.
Yes. Yes. So what's your final diagnosis?
Okay.
What's your final diagnosis?
TB.
Yes. What is your next step?
So I will correlate with the clinical parameters of the patient, sputum and culture for AFP, contact
Excellent.
tracing and isolation.
What is the name of this sign?
And
What is the name of this sign?
gibbous
Excellent.
deformity of the spine.
Okay. When you see gibbous deformity, what should you exclude from the MRI?
Metastatic lesion or spinal cord compression.
Excellent. Yes, excellent. Thank you, doctor, so much. Take some home message. This cervical X-ray is very critical. Why? Number one, you did very well when you talk about the erosion here. And I think 2, 3, 4, 5, 6, 7 here. But the most important and very clear, the prevertebral, my colleague. There is very, very obvious prevertebral thickening. Here in front of T2, it should not exceed 6 mm, but I think this is about 20 mm. So there are very obvious, a very large prevertebral thickening collection, whatever, and you exclude the presence of any gases. Okay. Next, the examiner gave you this one, and you did very well. There are a right paravertebral collection here, or at least if we are not sure this collection or not, there are widening of the paravertebral stripe, and it looks like irregularly related, so it is collection. When I ask you, do you have any clue here that can prove this is TB or not? The examiner will bring you something like this. This is an exact exam case. He will give you cervical spine, okay? And you are answering everything. You are very good, but he asks you very, very malignant question. Do you have any clue to prove TB or not? He give you cervical spine, and you should go down and ask him to change to the lung window, the first one, okay, to see any reticulation or any lung infection. And if you concentrate here, there are some infection here or some consolidation. There are some changes here in the apex. Here and here, there are pleural thickening or fusion, whatever. Okay. I repeat the question again in the MRI. Repeat the question. Okay. Do you have any clue? Look at the lung. What happened for the lung? And then I give you this axial. Look at the left lung. What is this? What is this? It looks like parenchymal abnormality, I think. See, because this is the heart. By the way, above, there are something here at the hilum, just beside the hilum. So the lung looks like infected, and this is a very, very great proof of a multisystemic TB, because almost the TB will start as a pulmonary TB, and it will be then disseminated uh, hematogenously to be multisystemic like this in the spine or whatever else in the genitourinary system. Genitourinary system is very, very common. The second common TB dissemination after, yeah, after the pulmonary infection, one of the most important to exclude the genitourinary tuberculosis. So it was a multisystemic TB complicated by Bot's disease and Gilbert's deformity. All of us know Bot's and Gilbert's deformity. Okay, this case gave us a very important idea how to tell the examiner before he asks what is the name of this sign. This is Gilbert's deformity. You did very well, doctor, when you talk about there are not any intraspinal extension. Okay, we should look here down. The best, in my opinion, is the axial. Look, the cecal sac is completely convex. The cord is not at least in this level is not compressed. Okay, but the area of concern is this one because Gilbert's deformity slightly or mildly indenting the cord here. Thank you, doctor, so much. Next candidate. Next candidate.
Assalamu alaikum.
Alaikum salam. This is 40-year-old male patient presented with chest pain after fracture of his femur. Go on.
Doctor, can you please scroll for me as
Yeah, I'm scrolling.
on?
Don't worry. Scroll.
Thank you.
Sorry,
So this
sorry, the history. Chest pain. So this patient is 40-year-old male patient presented with chest pain, fever, and tachycardia after a recent open heart surgery. Another case. Okay. Go on.
this is a CT chest with contrast, soft tissue window. I can see there is a large left-sided pleural effusion. There is also a large collection.
You can
noted
stop
at the
me.
side of
You can stop me at any slice of interest for you. Go on.
there is a evidence of recent surgery
Yes.
with dehiscence. There
Yes.
is widening between the sutures, and there is a soft tissue and rim enhancing collection with air locus noted within the surgical site,
Yes.
with extension into the mediastinum.
Yes. Hello? Hello?
Aorta.
Again, please. Again, I can
I
repeat.
would like to scroll to check if there is any aneurysm or any involvement of the aorta.
Okay.
Or any lymph nodes. I do not see any lymph nodes. I do not see any aneurysmal dilatation.
Yes.
There is
what's your-
left-sided pleural effusion with the underlying lung collapse.
Yes. What's your opinion?
This is post-surgical infection, dehiscence with collection and mediastinitis.
Okay. What is your next step?
I would like to urgently inform.
Hello? Hello?
I would like to urgently inform the physician for surgical intervention.
Okay. What do you think? This mediastinitis is very, very urgent pathology, or mild urgent, or moderately urgent?
Yes, it's very urgent.
Why?
Because the risk of sepsis and
Fatal.
maybe aortitis. Yes,
Fatal.
yes, it's
It is
fatal.
completely fatal. What other causes of mediastinitis do you know? This is post-surgical. Okay. What else?
Mhm.
I'm asking a general question because the examiner may do like this. They enumerate some of the most
Maybe in
important.
patients with immunocompromised patients
What else?
on chemotherapy and I know fibrosing mediastinitis.
I'm asking about mediastinitis like this. Post-surgical, number one. What else? Give
A trauma.
enumerate. Yes, trauma. What else?
Um,
What is the most common cause? Most common cause of mediastinitis? Very, very common. Very common.
esophageal rupture.
Excellent. Either from foreign body or perhaps syndrome. What else? Another very important cause of mediastinitis. I will help you. If you have infection here in neck,
Mm.
tell me.
Uh,
Yes. May
Ladric
explain.
angina.
Yes.
Infection that is involving the dangerous space.
No, dangerous space. I think dangerous triangular or dangerous space. Anyway,
I don't know.
any neck infection can spread either to the anterior, middle, or posterior according to its site. If, for example, if you have here perivertebral abscess or leading angina, can spread through any part of the neck, anterior, middle, posterior, to down to the mediastinum. Thank you, doctor, so much. I just bring this case because it is very unfamiliar for us what happened here. Even if the examiner didn't give you the history, and I expect many examiners have the right to do this. Why? Because here there are many beam hardening artifacts, and the sternum looks like abnormal. There are a defect here. Okay, what happened? And there are soft tissue. Look, there are soft tissue with gases. Then if you look down, go down, this soft tissue and the gases surrounding the heart completely, surrounding the heart completely. Go down, so it looks like status postoperative. And up on it, there are infection. Infection here in the anterior chest wall and in the side of the operative bed. But when the infection is around the heart, okay, this is mediastinitis. Look at the lungs. Look at the lung. The lung is completely no any infection. So we must be very clear. Infection around the heart in the structure not involved in the lung. So we are talking about the mediastinum. Mediastinum is the space between both lung and the sternum anteriorly and the vertebral column posterior. It divided into anterior, middle, posterior. Okay. And above the level of, I think, T4, it is a superior spine. Somebody may told me, doctor, I should rule out any superior extension. Yes, you are right. And any inferior extension. Yes, you are right. What is the next step? Urgent surgical drainage. Urgent. Very, very fatal. The mediastinitis. Thank you, doctor, so much. Next candidate. Next candidate. Hello? Hello? Next candidate. Candidate 3. Professor, candidate 4. Any candidate ready? Hello, my colleagues. Hello. دكتور سارة. Sorry, my colleagues, for some internet problem. Candidate 3, are you ready? Hello? Candidate 3. انتوا سامعيني كده يا دكاترة ولا لا؟ الو؟
ايوه سامعين حضرتك يا دكتور.
طيب يا جماعة، الكانديديت اللي عليه الدور لو مش جاهز اللي بعده. طيب كانديديت 3 خلص. طب كانديديت 4. طب حد يا جماعة يحب يشارك ولا ايه؟ طيب احنا المفروض معانا 6 ولا حاجة.
السلام
الو؟
عليكم.
عليكم السلام.
Yes,
Yes,
I'm candidate 4.
yes, welcome.
Okay,
Okay. 1 second.
sure.
Doctors, because I think we lost many candidates. Anyone wanted to participate, please text at the chat, because I think I need another 4 candidates. Anyway, doctor, this is a 30-year-old male patient. He presented at the emergency department with severe hemoptysis. Go on.
Okay. I'm presented with an axial CT scan of the chest lung window. The most striking abnormality is cavitary lesions noted in the right apical area as well as the upper zones. I would also like to systematically review to look for other lesions. Okay, so these cavitary lesions are thick-walled with fluid levels, most predominant in the basal zones bilaterally. So there is epicobasal predominance. I can
Yes.
also see bronchiectatic changes with
Yes.
scattered ground glass opacities.
Yes.
There is an area of consolidation noted in the left anterior lower zone with air bronchograms within. I would like to scroll further.
Down or up?
Up, please. Okay, so these bronchiectatic dilatations or changes of the bronchioles, they are thickened and in like forming cystic lesions, as well as, can you please scroll down?
Yes. What's your diagnosis?
Okay, so it's predominantly in the lower zone. Also, I see that the heart contour is on the other side, which says situs inversus. So with this bronchiectatic cystic dilatations, I would think of Cartegner syndrome.
Yes.
I would like to look at the mediastinal window just to confirm. Yes, so the heart is on the right side. I can also see that the liver is also on the other opposite side as well as the spleen. So total situs totalis.
Yes.
In this patient, I would also like to look for sinusitis.
Okay,
So I would like to
do you
review some.
remember, doctor? Do you remember?
Yeah.
Do you remember the main presentation of this patient? Do you
The main
remember?
present.
Yes. What is the main complaint of this patient?
So they present with recurrent infections.
No. No.
Okay, so he was, sorry, massive hemoptysis. Sorry, the
Yes,
history. Yes, yes.
yes.
So,
Do you
yes,
think
sorry.
do you think the examiner is so kind that he will give you a very clear case like this?
No. Okay, so
Hmm?
I would like to look for possible reasons for the hemoptysis. I would like to look at the
Hmm.
pulmonary arteries. Could
Okay.
you please scroll?
Yes.
Uh, okay. Is this okay? The pulmonary arteries do not look dilated. Um, okay. I would like to also review in the coronal axis.
No coronal.
Okay.
This is the only available. Look here and tell me. Look here and tell me. What happened?
I can see that there is a blush or maybe aneurysmal dilatation of the subsegmental pulmonary artery.
Again?
I'm not sure. I can see like an aneurysmal dilatation of the subsegmental right-sided pulmonary artery.
No? What
No.
else? What other causes of hemoptysis?
So we can have bronchial artery
Okay.
dilatation.
Could you see any clue here?
Uh, is there something around the descending aorta? I'm not sure, doctor.
Okay. If you are not sure, what is your next step? This patient has hemoptysis and the clinician wants to know the exact cause. The pulmonary artery here is completely normal, and this
Yes.
patient has cystic has bronchiectasis. Whatever the cause, the clinician would, this is not his business. What is the cause here? This is a life-saving case. You want?
Yes.
I'm speaking about the bronchiectasis. You want to know the cause of hemoptysis. What is your next step?
Uh, I would like to.
Where can you pick up any abnormality of the bronchial artery? Look here. Did
Yes.
you pick up anything? I will help
Maybe
you.
a
What is this?
interventional radiologist.
Yes, what is this? By the way, it
This
is very
is.
difficult case. Very difficult. What is
I'm
this?
sorry, doctor. I'm not sure, but maybe a branch of the. I'm not sure.
Yes. See, what is this? See, look, look.
It looks like dilated or collaterals or tortuous
Okay.
vessels.
What
Yes.
happened here? What happened?
Okay. So this is uh interventional like study angiogram, which shows that
Mhm.
there is dilated tortuous vessels arising from the pulmonary artery, most likely the, no, I think it's the bronchial arteries.
Yes.
So
So,
this could be the cause of the hemoptysis.
okay. And this is the
I would
next
like
step.
the next step would be embolization to
Okay.
stop the hemoptysis.
If you are in a hurry, okay, which
Yes.
material you will use to embolize any artery? You want something very, very rapid to get a very, very rapid.
So
Mm,
it depends on the size. However, I would use gel foam.
okay, but gel foam is temporary. So,
Yes.
Yeah, this is one of the drawback. Gel foam is very rapid and they give immediate result. That it is temporary. What does it mean? After 2 or 3 days, it may be recanalized and the artery may rebleed. So,
I would also suggest coils depending on the size.
okay,
Coil embolizer. Yes.
could you enumerate for me the most dangerous or common side effect complication of bronchial artery embolization?
Um, I'm not sure, doctor. Maybe there is the embolization, so the emboli can go to other vessels. I think maybe the spinal artery.
Spinal artery, yes, and it will result in
Paralysis,
not paralysis.
like
It will. Okay.
infarction. Yes.
Yeah. 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 Excellent. Thank you, doctor. Really, it was very
Thank
difficult
you.
case. This is Kertegner syndrome with hemoptysis. My colleagues in the level of very, very great certificate like FRCR or Arabic board consultant level, the cases almost are at the consultant level. So the examiner give you something like this, don't trust the examiner because it's very clear Cartagena with cystic bronchiectatic changes. What else? The main complaint, remember the main complaint. The main complaint is hemoptysis. So don't satisfy of search. Please don't satisfy search. Search for other causes. Okay, you did very well when you talk about, doctor, I'm worried about there are aneurysmal dilatation here or not. Okay. Okay, but what else? What else? You search well in the main vessels, but the main vessels were normal. What about the bronchial artery? How could we detect the bronchial artery in the mediastinum? Okay, because bronchial artery is a systemic artery. It get out, it arise from the aorta. So look here at the mediastinum. At least there are some abnormal vasculature here. At least, okay? Yes, the oral exam depend on a lot of guessing. Why? You have only two causes of hemoptysis here, and you find abnormal vasculature in the mediastinum. So you don't know exactly what it is. So it is by exclusion, it may be the bronchial artery. Your next step is either CT angio or convention angio like this. They immediately canalize the right bronchial artery and it is tortuous, engaged, it is hypertrophied. Okay, when it is hypertrophied like this, it can bleed. And the next to it is embolization. Take care, my colleague, embolization is a very common question in any exam. Why? Because it is one of the very important and urgent and the simple interventional procedure. At least we should know the minimum information about the arterial embolization. Thank you, doctor, so much. I will take from the list. I see that many doctors are volunteers to participate. Dr. H, first one who, Dr. H, who first one who wants to participate. Are you ready? Hello? Okay, Dr. Najm.
Hello.
Hello? Yes?
Hello. I'm candidate 3. I had a technical issue
no
with the
problem.
mic.
Okay, no problem. You can participate. No problem. You are welcome. 35-year-old male patient presented with generalized tonic seizures followed by acute dyspnea. Go on. I will scroll
Yeah,
to
I am
you.
presented with contrast enhanced CT scan of the chest soft tissue window. I can see that there is right-sided large pleural effusion along with right lung collapse. There is also on the right adjacent to the chest wall, there is oval-shaped convex hyperdense structure seen. I would like to scroll up and down. Okay. Can I see the other lung window? Can I see the lung window?
See no lung window. Concentrate in this, please.
Okay. So the patient presented with seizures, and there is large pleural effusion and right chest wall high density structure. So I'm thinking about chest wall hematoma on the right side.
Okay. Okay. How
In my
could you
routine
confirm?
practice,
How could you confirm?
on my routine practice, I will measure the density of this structure. And also, I will look if there is any adjacent rib fracture.
Okay. How could you confirm this is why is this not mass and enhancement?
Because I think the border of this structure is smooth and well-defined, not irregular.
How could you confirm radiologically this is not a mass? It is like you said, hematoma. Because in my opinion, it is an enhancing mass. How could you prove or
Okay, I will check the pre-contrast.
Okay, 1 second. Pre-contrast. So this is the pre-contrast. This is the post-contrast one. This is the post-contrast in your left hand. This is the pre. What do you think?
Okay, when comparing the pre-contrast with the post-contrast, the structures appear high density also on the pre-contrast. So in my routine practice, I will measure the house field unit to confirm that it's not enhancing mass, it is a hematoma.
Yes, doctor. Do you remark any difference in this? What is the name of the technique here? The technician used one of the tools of the software here. What do you think? Which option does the technician use?
It is a MIB imaging.
Excellent. This is MIB, my colleague, very important. Look here, MIB gives you the vessels, especially very clear, more than, for example, I think the rate is MIB, not MIB. This is not MIB. Train your eyes, my colleagues, train your eyes, okay? Because it comes by training. This is MIB. MIB can draw the vessels very, very near from a 3D like. Okay, and when you are searching for any vascular abnormality, use the MIB in coronal. This is the best in any examination. This is not MIB, by the way. The only MIB is this one. This one. Look at the bone here. Looks like natural bone, not an imaged bone. Very big difference between this and this. Train your eyes in the MIB because it is very simple and important question. By the MIB, we can evaluate all the visits very well. And also for lung nodules, when you are in lung window, if you want to pick up any small nodule, change to the MIB. And the MIB have also many options in the thickness, but at least you must know the cause, the image. Look here. I think the examiner may start with this X-ray. There are ground glass opacity, and there are here some lucency. Okay, but the patient is an acute patient, acute dyspnea. So after CT, you will find this one. Okay, Thank you, doctor, really very much, because it is very little bit tricky case. Why? Because it looks like enhancing case, because I give him the post contrast. Looks like enhancing this lesion with pleural effusion. Very simple. But he was very wise when he told me I will compare with the pre-contrast. Look here, very hyperdense blood clot. Okay, whatever the cause. Okay, the next step will be sure a CT angio or whatever, any type of angio conventional, but at least you lighted the pathway in front of the clinician. This is a hemorrhage and this is a large hematoma. So we must concentrate in the vessels. Okay.
Okay.
A second point, I think this is not, you mentioned in the beginning, this is post-contrast chest CT. No, this is angio. I think this is angio here, at least. Look, because in the chest, we didn't do arterial. Yeah. Chest, conventional chest is venous. Look here, the pulmonary, see the pulmonary, very, very bright.
Yes.
Okay, this is not, by the way, pulmonary angio, because in pulmonary angio, we will not see the aorta, but at least this is angio. This is very important to tell the examiner the correct name of the technique. Very important. Okay, sure, we need more and more MRB and more phases, even or CT or conventional angio to pick up the code. But at least you did very well when you pick up the diagnosis. Doctor, I have one question. Do you think it is better for this patient to put a drain and do what is the correct location of the drain?
I will suggest doing drain to drain the pleural effusion, not the hematoma. So I will
How
insert the
can,
drain.
one second, could you differentiate between both of them? And how could you differentiate? You will, if you will drain, you will drain. You will see. But you give me very excellent diagnosis. This is a hematoma and the bleeding. So, next step, do you prefer to drain now or not? And if you prefer, what is the correct location for the catheter?
Yes, because I can see that the right lung is almost totally collapsed, and patient may have a lung may have respiratory symptoms. So I will suggest to do a drain for the large associated pleural effusion. However, I will suggest to put the drain away from the hematoma. Hematoma, I think, need surgical consultation.
One second.
Yes.
Exactly what should we do? Number one, to find the bleeder. Number two, to embolize the bleeder. Okay? Why? Because all this fluid and hematoma exert a mass and the tamponade effect on the bleeder. If you drain before embolizing or including the bleeder will bleed more and more. I'm talking about the correct chronological sequence. First, we should diagnose the bleeder. Second, we should occlude the bleeder. Later on, it may be drained. Because we are not, by the way, we are not cardiothoracic doctors. So we didn't know the exact treatment. But if you give this sequence for the examiner, will be happy. He wanted to listen from you. I will not drain before including the bleeder due to this very happy and very good mass effect and tamponade effect. Okay, my colleagues, very important.
Okay.
To prevent the rebleeding. Thank you, doctor, very much.
Thank you.
Dr. Najm, you can participate. Hello? Anyone wanted to participate, my colleagues? Anyone? Even for not from Arabic board, not from the list. Anyone wanted to participate?
Yes,
okay,
participate. Yes, me want to participate.
Yes, doctor.
This is the X-ray test.
Dr.
This is
Mujahid.
the X-ray test. Yes, yes, yes.
Okay, doctor,
This is
this
the
is 70-year-old female patient complaining of increasing dyspnea. Go on.
history, please. History, repeat.
Dyspnea. Dyspnea.
This is the X-ray chest of 21-year-old patient with history of dyspnea. This is the X-ray chest frontal projection. There is a reticular shadowing is seen in the lungs bilaterally, more pronounced on the left side. The heart water appears shaggy on the left side. There is no loss of lung volume is also seen on the left side.
Mhm.
There is no evidence of any pneumothorax.
Mhm.
The bones appears grossly normal. So these findings may represent interstitial lung disease, but it is usually this lung disease occurs bilaterally. So this is
Yes.
unilateral. Second, it could be some old process which is occurring on the left lung more marked. So the proper this patient should be followed by the HRCT chest for further
Mhm.
evaluation.
Mhm.
No pneumothorax is seen on this study. No bones are also appears unremarkable. I will also
Mhm.
see the previous X-ray. Is the previous X-ray is available?
What history should you ask about?
Previous X-ray. I will also see the changes were present or not present at that in
No,
previous
no
X-ray.
previous X-ray. Which history should you ask about?
Sorry,
Which history do you want to ask the patient about?
I want to ask the history of any birds or any history of allergy and history of immunocompromised patient, or if
What
any
else?
history of
What else?
history of any previous infection, just like
No previous
tuberculosis.
infection. Unilateral reticulation like this, and it has a very specific distribution. And the patient is old. What first come in your mind?
The COVID history of COVID. If the history of
No,
COVID is a patient,
no
atypical
COVID
pneumonia
history.
was present.
No COVID effect. What is? Unilateral, pre-hilar, pre-bronchoscopy, like this, like this. So what come in your mind?
This could be any history of radiation therapy.
Radiation
Patient
therapy
has any
will,
history.
the field will not all over the whole lung. You are very near. What else? What before radiation? You wanted to ask something before radiation.
Could be chemotherapy, some chemotherapy.
Not chemo. Something before both of them. One pathology. Look again, the patient has history of melanoma. Okay? The patient has history of melanoma. Okay, what is your next step?
This could be unilateral pulmonary edema
Or
due to aspiration.
yes, unilateral reticulation like this may be unilateral pulmonary. Okay, but what else in patient who has a history of malignancy?
This could be metastatic deposits, early metastatic deposits.
Okay, look at the CT. What happened here? What happened?
This is lymphadenous carcinomatosis.
Yes. Why? Why?
Reticular shadowing, there is infiltrates and there is reticulation. These likely represent lymphadenous carcinomatosis.
Not just reticular nodular. And what about the distribution? Where exactly?
They're mostly in the central area. Bronchoscopy marker central.
What?
Upper lobe, in middle lobe, and in the perilymphatic region, the
Yes,
peribronchoscopy marker, and
pre-lymphatic.
central area.
Yes, pre-lymphatic. What is the pre-lymphatic? Pre-bronchoscopy. Pre-hilar. This is the most important. And pre-fissure. Look at the fissure here. See? Non-uniform thickening. So it was a lymphangitis carcinomatosis. One of the most important causes of unilateral reticulation. Number one, contralateral transplants lung with ipsilateral ILH, interstitial lung disease. Number two, edema, but the heart here looks like normal. Number three, laryngitis carcinoma. If the examiner gives a case like this and he just told you dyspnea and you enumerate the different causes, you are right and you will be happy. And you must ask, doctor, did this patient, I see the heart is normal, so it doesn't look like pulmonary edema. Does this patient have any history of malignancy? He immediately will tell you yes. Or if you see a unilateral mastectomy or a unilateral axillary evacuation with some surgical clips here, it's very, very clear sign of your lymphangitis carcinomatosis. Okay, so
Okay.
enumerate, search for signs of malignancy. Even here, you may see any signs of abdominal surgical operation or previous malignancy. Number one, search for signs of malignancy. Number two, ask of the history. Number three, enumerate at least. Okay, thank you, doctor, so much.
Thanks.
Lymphangitis carcinomatosa, pre-hilar, pre-bronchovascular, and pre-fissural around the fissure. And sometimes here at the peripheral, because we have central lymphatics and the peripheral. Okay. Dr. John Cortis gave a very nice name, lumpy pumpy, but this is not lumpy pumpy. What mean nodular thickening, but this is not a scientific or a radiological term you mentioned also. Okay, look here, very characteristic and very important in any exam. Anyone wanted to participate, my colleagues? Who wanted to participate, open the mic and come immediately.
Yes, sir.
Yes.
Yes, I am Dr. Hisham. Oh, okay, can you please, madam?
Okay, Dr. Akila and
Yes, sir.
Dr. The next one. Okay.
Okay, sir.
Welcome, Dr. Akila.
Thank you, sir.
20-year-old male patient presented with respiratory distress and high D dimers.
Okay. May I request the control?
I will
Or
help
will
you.
Okay. So I'm presented with the axial CT chest post contrast of a 20-year-old male patient who's presented with the respiratory distress, I guess. Yeah.
Yes.
Okay. So
Yes.
this is a mediastinal window. Sir, will you please scroll? I just wanted to look at from top to bottom, and then we'll comment on. There are multiple bilateral areas of nodular soft tissue thickening involved in both the lobes. I just wanted to look at the vessels if I can. Pulmonary vessels. Okay. The main pulmonary trunk, the right and left pulmonary arteries appear normal. I cannot appreciate any filling defect. However, I think pulmonary veins on the right side,
Yes.
it appears showing a filling defect in it. Yeah, and peripheral wedge-shaped areas of opacity are also seen bilaterally. Multiple, actually, these are.
Yes.
Yeah, so can I look at the lung window, sir?
Good.
There are no effusions on either side. Yeah, on the lung window, I can appreciate there these wedge-shaped areas of consolidation with internal cavitated area. Cavitations is also appreciated. I can also appreciate cavitating lesion in the left perihilar region as well.
and there is patchy areas of ground glass opacities as well. So these, as the patient is young and present with acute onset of respiratory distress, these could represent septic emboli
Yes.
and with the peripheral distribution, and some of them are showing cavitation and with ground glass uh, surrounding and ground glass opacity in the surrounding area. Septic emboli with the filling defect in the pulmonary veins. Um, yes.
What is your next step?
I would urgently inform my findings to the clinical team and would refer the case to the respiratory chest clinic. Chest team, respiratory team for further management and rule out the cause of the septic emboli. Young patients, if there is any history of IV drug use, it would be
Yes.
important. Yeah, then I would also like to evaluate the heart and echocardiogram to see any vegetation, sign of endocarditis. And second differential could be of vasculitis origin.
A
Second
junior,
possibility could be
a junior
yeah.
radiologist asking you in the department to, you are an interventional, to do embolectomy, or if it's possible to do embolectomy for this case. What is your answer?
Embolectomy, sir, I don't know, because embolectomy from the pulmonary veins, I think I haven't heard about anything. Yes, if there is a pulmonary artery and saddle embolism in main central arteries, yes, embolectomy is done for that. But I
In
don't know
another
if
words,
other veins.
he is asking, is it possible to give thrombolytic therapy or embolectomy for this kind of patient? What is your answer?
I think systemic anticoagulation can be done.
Are you sure?
But
Are you sure?
mm,
Revise your diagnosis in case of septic emboli. In case of septic
uh,
emboli, what is the first line of treatment? Septic emboli,
they
anticoagulant,
give
or
I think
yeah,
antibiotic treatment for
yes, great.
the
Antibiotic,
underlying infection
yes.
and anticoagulation for thrombolysis.
No. See,
Yes,
see. What I know,
yes,
the
yes,
first line should be
yes,
antibiotic first. Why? Because the vessels here very friable. It's an infection. Okay. At least antibiotic should be done
yes,
first, and
yes.
this is 100%. Second, and thrombolytic therapy maybe or may not, but you should mention to the examiner antibiotic is first to confirm that you are a safe radiologist and this is an septic emboli. This is the point. Okay. Thank you,
Yes.
Dr. Akila.
Yeah.
Like usual, your style is amazing. You pick up the finding
Yes, thank you.
from the first look. I wish from you also to give us some other differential. Doctor, why does this CT, why didn't you include other differential diagnosis like Wagner, like cavitating,
Yeah, that
metastasis?
can be, but actually I saw the thrombus. Yes, they
Yes.
because
And what
cavitary
else?
region, yes, we have a long list
Yes,
of
yes.
differential.
And what else?
Yes, and particularly for the young patients, we include vasculitis,
What else?
particularly granulomatous cholangitis. We can also give
What sign? What sign
any
in this
cavitating
CT?
meta.
What sign? Other sign in this
Mhm.
CT against both of them, either cavitating metastasis or Wagner. There are very obvious signs. The
Against
distribution
Wagner's.
against, yes,
Yeah.
the
I mean,
distribution.
distribution, they are also peripheral distribution, and particularly basal is
Yes,
more in
wedge
favor
shape.
of emboli. Yes.
Yes,
Yes,
thank you,
wedge
Doctor, so
shape
much.
infarcts.
Because
Thank you.
one colleague asked, why does it, this case, why doesn't it why doesn't this case diagnosed as Wagner or metastasis? Because look,
Mm-hmm.
wedge shape peripheral, very classic for pulmonary infarction. Okay, very classic.
Yes.
You can diagnose this as a cavitary lesion upon conventional pulmonary embolism if this patient is a known patient with pulmonary embolism since 1 to 3 weeks, and upon it, yeah, I mean that after uh, the conventional pulmonary embolism, some cavitary changes or cystic changes may be okay, but this patient is very acute. This patient of today,
Mm.
it is impossible
Yes.
to cavitate within 24 hours. So, first
Yeah.
possibility is septic embolism. Thank you, doctor, so much.
Yes. Presentation is important. If the patient is acutely presented, we keep those different
Fever,
kind of differential
fever,
in the list. Yes.
fever, but I didn't tell you that the patient has fever. Why? Why? To make it more difficult. And the examiner will do like this. We should ask about history of IV drug abuser or fever, like Dr. Atila did. Thank you so much.
Thank
Uh,
thank you, sir.
Next candidate. There were one candidate who wanted to participate. You can open the mic, doctor.
Yes, sir.
Yes, welcome, doctor.
Sir, thank you, sir. Thank you very much. Could you
Doctor,
listen me,
yes, very
Dr.
well.
Vaidesham?
Welcome.
Sir,
Yes.
sir, the patient presentation is 40 years old with 1 year history of progressive sinusitis, voice changes and swelling in the middle finger of
Okay,
both hands. Okay,
go on.
I'm provided with a preview of X-ray hand.
Mm,
There are multiple lytic
mm.
destructive lesions are noted along proximal and middle phalanx of middle finger with soft tissue swelling. Uh,
Yes.
there is cortical irregularity on medial and lateral aspect of proximal and middle phalanx, and along with cortical thinning and cortical thickening along the middle phalanx of ring finger.
Mm,
I want to see different views, lateral view.
mhm. Lateral view. Yes, this is the lateral.
Okay, sir, there is a cortical irregularity, uh, punched out lesions along the middle phalanx of middle finger with the soft tissue thickening.
Mhm. What is your next
Uh,
step?
s- Sir, I would like to ask for the history of the patient, keeping the history of sinusitis uh, and uh, I would like to see excess skull.
Okay, but I have one question. What is the name of this appearance?
Sir, this is mm, I don't know, sir, exactly.
Okay,
Uh,
I think you want PT skull. Okay, this is a skull and neck. Skull and neck. Okay.
right, sir. Thank you, sir. Sir, I'm provided. Right, sir. I'm provided with axial and corneal views of the uh, skull and neck. Sir, please scroll for me.
Yes, yes. It is still download. What happened? See, look at these
Sir,
slides. Very important one.
sir, these are soft tissue axial slices, post contrast.
Yes.
So, Sir, I'm a little bit lagging. I
One
cannot
second. Look.
hear,
Yes.
and the slides
Stay
are a
low.
little bit lagging. I cannot hear you
Okay.
properly.
Look here. What happened here?
Sir, sir.
Look.
Yes, sir. Sir,
One second.
sir,
One second.
sure, sir.
Internet problem. Sorry. Look here, my colleague. What happened here? This is enough. What's happening? Look.
Sir, there is erosion and
Yes.
cortical restriction of nasal septum, sir.
Excellent.
Superior alveolar ridge, sir. Sir, sir. Vomer bone, sir. There's cortical irregularity and destruction of vomer bone.
Yes. Look here also. What happened?
Sir, sir. So there is cortical irregularity and erosion and lucency is noted along superior alveolar arch.
Okay. If I told you the key of this image is this case here. Here. This
Sir,
is a very characteristic sign for a very specific disease. Number one. Number two, this disease is also diagnosed from here. So what do you think?
sir, keeping the sequential images, I can think of Wagner's granulomatosis because
Did
there's
you find any clue for
sir,
Wagner here?
sir, I do not find any cavitatory lesions in both lung
Okay.
fields.
Okay. What did you find here?
Sir, in X-ray chest AP view, sir, I can see in the neck region there is narrowing of
Okay.
sir, areoepiglottic folds.
Okay, but concentrate on the chest. What happened? What happened here?
Sir, both lung fields are clear. Sir, both cardiac shadow is normal. Trachea is central. Both
What
are,
happened in both hilar?
sir,
Hmm.
sir, there is a
Yes.
prominence of both hyla.
Okay. What come in your mind? See,
Sir,
finger with lace-like infiltration or
yes, sir. Yes,
erosion.
sir. Sir, sarcoidosis, sir.
Yes. Yes, sure.
Right, sir.
Sure.
Right, sir.
See, my colleague,
Right, sir.
okay. What is your next step?
Sir, I would like to see CT chest, sir.
Okay. How can you confirm 100% this is a sarcoidosis? Which test? Which test is
Sir,
100%? Mm.
sir, we can test them on, on gallium scan and, sir,
But
ACE levels.
gallium scan is not a diagnostic. This is just to pick up the extension of
Right, sir.
the sarcoidosis. But which test is confirmatory by 100%?
Sir, Yeast levels, sir, we compare it with the yeast
No,
levels.
no. The only confirmatory by 100% is a biopsy, not ACE is يعني a prognostic or a general, because it may be elevated in any other state. But for sarcoidosis, the only 100% confirmatory test is a biopsy. Besides, okay,
Right, sir.
this is if you were asked this question. But generally, sarcoidosis is diagnosed by like this bilateral symmetrical hilar lymphadenopathy, enlarged. Okay, and there may be
Right.
something here, by the way, but I'm not sure. And here, this very characteristic, lace-like infiltration of the bone, erosion,
Right.
and soft tissue. Okay, what happened, my colleague? See, this is a sarcoidosis with osseous and nasopharyngeal involvement. What happened here? The most dangerous part is here. Here, this one. What happened? Erosion. Look here. Perforation for the
Yes.
nasal septum. And if you go down, there are here the upper part of the mandible destruction. And here, there are epiglottic thickening and thickening here. What is this region? At least the posterior part of the larynx. If we didn't know the exact anatomy, this part is upon the arytenoid cartilage and the upper part of thyroid cartilage. There are soft tissue thickening. Very, very confusing case. The key is here in this lace-like, very pathognomonic for sarcoidosis. And
Right.
here, look here, what happened here? The lung parenchyma looks like really, really very normal. No any obvious pathology here, apart from this lymphadenopathy. What happened? Bilateral symmetrical hilar, and as I
Right
mentioned,
paratracheal.
right, but 1 to 3 signs. Lambda sign.
Yes, sir. 1, 2, 3.
The name is assigned to the gallium scan, but no problem. So very subtle sign diagnose a very systemic disease, despite the lung parenchyma is totally normal, but the hilar and the right paratracheal lymph node is very, very solid. Okay, my colleagues. Okay.
Thank you, sir.
Why
Thank you
not
very much.
TB? Why not TB? Okay, very good question. Number one, very, very symmetrical lymphadenopathy. Number two, if you look here, even here for the spine, look, no any spondylodiscitis at all, no any berry. Look here, the spine is totally normal. No any collection here, prevertebral. This is not the common signs or the common picture of TB. Look, the spine is very normal, very clear. If you look here, did you see before any TB caused nasal septum perforation? If you told me this is maybe Wagner, it is acceptable. This is cocaine addiction, okay, acceptable. Okay, did you see before any TB caused erosion like this? It looks like mass, by the way, here. Looks like mass. See? Erosion here. So I can excuse you in this neck CT because really it is very atypical. Do you think if the TB affected the neck, he will affect the epiglottis in the larynx without affecting the spine? Not logic. Okay.
Right, sir.
Somebody asked from the hand X-ray, it looks like TB dactylitis. No at all. Why? Look here, it is less like really. The TB caused something is spina ventosa. What is spina ventosa? The phalanx or the bone is markedly expansion. Okay? Markedly expansion, the bone itself, not the soft tissue. Search for the Google or Wikipedia for TB dactylitis or spina ventosa. Very different from this one. Very different. Okay, my colleagues. And do you think TB will start with lymphadenopathy like this without any parenchymal affection? See, generally we are a radiologist. We are not a pathologist. So we are taking with the available radiological finding. Bilateral symmetrical lymphadenopathy like this suggests sarcoidosis more than TB. TB is a symmetrical lymphadenopathy and almost associated with any type of parenchymal affection, especially at the apex. Even here, there are even no any pleural segment. A big difference. Look here at the chest CT. Completely normal lung parenchyma is not acceptable by the way in TB. Not acceptable. Why? Not acceptable because TB start as at least as John's focus here. Any small focus here of calcific. Okay. Anyway, if you put TB as a less likely differential diagnosis, okay, but don't put it before the call. Thank you for all of you, my colleagues. I hope we can do more and more lecture. Tomorrow there are one lecture at the same time for all of you, but the candidate will be from FRCR because it is already before book. Thank you, Dr. Sarah, Dr. Tanya. Thank you for all of you. Goodbye.